Thank you very much. Pleasure to be here. Thank you, Mr. Morgan and Mr. Sisson, for inviting us. Thank you to the North Coast Economic Development Council also for the opportunity to present and give you some information about what's going to be coming our way. I'm a neurologist. I've been in practice now for 34 years. I actually began my practice at Tri-City Medical Center, where I still am on courtesy staff and participate with my partners. And also, because of the growing community over many years, started at Scripps 20, 25 years ago also, and have maintained my personal practice there for many years, where I've become interested in the rehabilitation of patients with traumatic brain injury, stroke, and the kinds of things that we see in an aging population to try to get them back to community, to work, to head of household, to various kinds of things that a person would want to do. But my personal interests also lie with Alzheimer's disease and related dementia and Parkinson's disease and things that are also age-related kinds of findings that patients will develop as they live longer. Our primary care colleagues have done a great job of keeping people alive longer so that we're seeing more degenerative diseases as this population gradually increases, as you'll see in a minute. I have great interest in research and have done clinical trials for many years. I am particularly interested in that because of a personal story. My father developed tuberculosis in 1948 and was told in the Chicago area to go to a sanitarium to die. I was not yet born, so you can imagine how the story turned out. So a researcher came in and actually offered him a new drug that the Army had just released called streptomycin. And they gave him the drug. They actually didn't even know how to give it. He inhaled it because they thought, well, he had a lung disease, so we're going to give it right into the lung. Well, it was sensitive, and he survived and came home, and I was born almost 9 months to the day after he came back. So I'm living proof that clinical trials actually work, that research is actually important. You're going to hear a little bit about the Alzheimer project coming up and how important it is. And it's not just smoke and mirrors, it's the real deal, what's happening here in San Diego County. I'm very proud to participate with the County of San Diego, with the Alzheimer Association, in these efforts. Thank you.
Thank you, Paul.
This is Mary Ball, by the way.
Hi, I'm Mary Ball. I have the privilege of heading up the Alzheimer's Association of San Diego and Imperial Counties. And just to thank you to the San Diego North EDC. What a wonderful event, a great turnout at this early in the morning. And these are the issues that we should be talking about as a community. And when we look at the aging of baby boomers, unfortunately, Alzheimer's disease and other dementias are going to be a big part of the aging population's lives and their families' lives. Many people don't realize that Alzheimer's disease today is the third leading cause of death here in San Diego County. And we have gotten that data from experts with San Diego County, and they've actually told us they think it might be higher than the third leading cause of death. And we're looking at, how do we improve reporting around Alzheimer's disease? At the Alzheimer's Association, our mission is really simple. We'd like to go out of business. We'd like to find a cure for Alzheimer's disease, but until that day, our mission is to provide care and support and information to people living with the disease and their families. So we serve thousands of families every year. We've got a team of social workers, and we want to help them on the journey that typically is an 8 to 10 year journey with Alzheimer's disease. And oftentimes, the people with the disease are cared for by their family members for the entirety of the disease. So if you leave here with one thing, it's that the Alzheimer's Association is here to support people in the community. Everything that we do is free of charge. We've got a 24-hour-a-day helpline that's answered by experts in the disease. Anyone can call it anytime to get information and support. Because I know that we all know people who have suffered from this disease and family members who are caring for people. So spread the word and let them know that there's help out there. Thank you.
And now we have our numbers ninja, Leslie Ray from the County Epidemiology Department.
Hi, I'm senior epidemiologist. What I do is I look for patterns, and I look for patterns in our demographics, in our economics, in our health outcomes, and how they're all related. Several years ago, the county launched Live Well San Diego, and the purpose of Live Well San Diego was really to bring three main components together that help us live well. Not just health, but it's building better health. It's also living safely and thriving. And so my job is to actually begin to pull all of this kind of information together, because it isn't just a matter of having medical care and getting a disease diagnosis and treatment. It's also, do you have a safe place to live, a community that you feel comfortable walking in? Do you have access to fresh food? Do you have an economic standard of living that allows you to enjoy life? So we look at all of these factors together, and that's one of the things I do, is bring together economic and demographic data with our health outcomes. 2 years ago, I was quite honored to be asked by Supervisor Jacobs' office to participate in the Alzheimer's Project. And my task was to figure out how many people in San Diego County had Alzheimer's, because we had no idea. So I have a brilliant team of epidemiologists that I work with, and we went about figuring out exactly what the impact of Alzheimer's and other dementias was on our county, and also what the economic burden, what that really meant in terms of dollars, as well as impact on people's lives. So that's what I've been doing the last year or so, and I've had the great pleasure to work with both Dr. Lobatz and Mary Ball, and it's been quite a personal journey as well, because in addition to being a lead epidemiologist on this project, I'm also a caregiver. My mother-in-law, in fact, I had about 3 hours sleep last night because I was at Mercy emergency room with her because her medications were not working, and she was having violent rages and assaulting her caregivers and things like that. So I know both sides of this story intimately, and I'm here to tell you I'm probably the bad news person. This is a huge epidemic that is upon us, and we have to do something with how we manage this disease, or we're going to face a real disaster.
Let's have our first question. I tried to keep these very broad so that they have room to run. They're all geniuses, so they have plenty to say. So my first question: how will care delivery change over the next 20 years?
So this generational change that's occurring is the most powerful force affecting healthcare. It is going to affect it in a number of ways. Not only is it going to cause us to have more people in healthcare, needing healthcare, but it's going to affect all those around us, both economically as well as personally, as Leslie just mentioned. 3 million coming on, 10,000 a day, as Paul mentioned, 1 every 6 or 8 seconds, something like that, turning 65. The vast majority of these individuals are going to shift over to Medicare from commercial insurance. So that's going to create this increasing burden on the federal budget. So 71 million will be more than 65 years or older by 2029. And that 2029 is a key time frame because that's when Medicare goes broke. unless something is done to change the financing of Medicare and Medicaid, Medi-Cal here in California. So the population of baby boomers is interesting. It's more racially diverse, more ethnicity. There's 20% currently are in minority groups, and that's growing. Definitely more educated than the previous generation. But my generation, the baby boom generation, has been more indulgent. And we have not taken care of ourselves quite as good as we could have. There's more obesity, there's more diabetes, there's more hypertension, cardiovascular disease, and these are drivers that are going to increase the need for medical care. So here you can see just a little bit about Medicare and Medicaid making about 23% share of the federal budget, and that's growing. And then out of that, there's inpatient hospital services and Medicare Advantage, which is basically like HMOs or or other organizations that are contracting with Medicare to actually provide full service. And then there's a variety of other services, including Part D, outpatient prescription drugs. It's a huge portion of the federal budget, growing every day as more baby boomers switch over to Medicare. So what are the transformative forces? I spent a lot of time thinking about this, and clearly number one right now is the Affordable Care Act. Patient Protection and Affordable Care Act. Whether you like it or not like it, it's here, and it is transforming the way medicine is done, both in hospitals and in outpatient settings. There's a addition, of course, of the aging baby boomers, and then the development of digital technologies, sharing of information, electronic health records is huge, and it has the great potential to improve our health, to help us to manage patient populations better, share information amongst health systems. Example would be, I get sick, I'm a member of Scripps, I go to Tri-City, Tri-City has access to my records so that I get good care in the emergency room there and they know what's going on, or Kaiser, or anything of that nature. So these health information exchanges are here now, and are tooling up, and are going to help really create better care. And then there's the science part. Incredible doubling, tripling of knowledge every few years at this point. New omics, genomics, proteomics, transcriptomics, and you name it, omics. Coming along, new types of discoveries, and the ushering in, eventually, of personalized health care that is based upon your genetic makeup, your background, what's going on, that can be tailored individually to the person. And then lastly, the demand for healthcare services is clearly increased. There is social networking now, and patient satisfaction has taken center stage as to how we approach our patients, both in hospitals and in my office. Very important, because now consumers are taking control and want better care, more personalized care, and that's clearly a direction that healthcare needs to go. And Medicare knows this, and part of the reimbursement policy that they have will be based on patient satisfaction scores. So my last slide, all of this, all of the different kinds of things that we are doing in healthcare, including the digital revolution, social networks, genomics, and other things that you see here, are all surrounding the patient and helping us to direct care in a better way. And what's happening now in terms of this health system change, the question that you originally asked, Paul, is that all of these things are coming into play now in one way or another. It's not going to be a single thing that brings us around to be able to create better health care for our patients. It's going to be all of these things together. And underneath all of this is the fact that we have an aging population, there is an increase in the number of degenerative diseases, a tsunami of Alzheimer's disease on our way, here now, coming more later, and the healthcare system is changing around that. There are a number of different things that I could get into in terms of how each health system and healthcare provider is changing. One thing you may have noticed if you've been in a hospital lately is that your primary care doctor no longer goes to the hospital. You now have hospitalists taking care of patients inside of hospitals that are dedicated to the hospital, that do efficient care, lower the length of stay, and get better outcomes. That's just one small example of how healthcare is changing.
Thank you, Dr. Lobatz. Well, I think I'm going to have to do some slides now, too. So if we could bring those up. I'm going to talk a little bit about local statistics and trends, but I'd love to see in this room, raise your hand if you have known someone who's had Alzheimer's disease or another dementia, known someone who's cared for someone, had a family member. If you look around the room, you don't need to see statistics, because you can see in this room, most people have been touched in some way by Alzheimer's disease. And unfortunately, given where the numbers are going, at some point we're all going to be touched in some way by Alzheimer's disease or another dementia. When we look at some of the local statistics, and many of these came from Dr. Ray and her team, more than 60,000 people today in San Diego County are living with Alzheimer's disease. They are taken care of typically by family members. We've got more than 150,000 caregivers who are caring for loved ones with Alzheimer's disease. And given sort of this state of affairs with Medicare and private insurance, very little is reimbursable for people with the disease. So about 80% of the time, for that 8 to 10 year journey, people are cared for at home by family members. And that is a tremendous burden on family members, given what happens with the disease and the length of time. And again, third leading cause of death here in San Diego. As I mentioned, the numbers are skyrocketing. And what's the number one risk factor for developing Alzheimer's disease? It's age. So as people are living longer, we're seeing the risk factors go up, and the number of people likely to develop the disease is increasing. So today, 60,000 people. By 2030, estimates are it's going to be close to 100,000 people just here in San Diego County. And unfortunately, Alzheimer's disease is the only disease in the top 10 killers here in the United States that today has no treatment or no cure. There's no way to slow the disease down at this point. And that's why research is so important. When we look at baby boomers, between 2015 and 2050, 28 million baby boomers are going to develop Alzheimer's disease. So again, huge numbers of people are slated to be impacted by it. And when we look at just baby boomers in general, over half of baby boomers will be living with Alzheimer's disease at some point in their life. Over half. So when we look at the future of healthcare and baby boomers, Alzheimer's disease and other dementias has a huge impact on the planning that we need to be doing locally and nationally to provide care and support for these people. And again, as I mentioned, by 2050, half of all baby boomers. When we look at spending, today, about close to a quarter of Medicare spending is spent on baby boomers living with Alzheimer's disease. If we look just in general about spending on Alzheimer's disease, even given the fact that there's not a lot of support that's reimbursable to families today, given that 1 out of every 5 Medicare dollars today is spent on someone with Alzheimer's disease. So as these numbers increase, Alzheimer's is going to continue to have an incredible economic impact and, again, a devastating emotional toll on families. It's wonderful that we're having these discussions because historically, Alzheimer's disease has been a disease that people have kind of whispered about, and there has been stigma attached to it. And through events like this and coverage in the newspaper, we're going to continue to raise awareness about this disease and drive more care and more dollars into research for a cure. Thank you.
Okay, so we may breeze through my slides pretty quickly because a lot of them are the same statistics. Basically, in 2008, we had a big shift, and Alzheimer's became the third leading cause of death in this county. It's the sixth leading cause nationally and the fifth leading cause in California. Clearly, something is happening here that isn't happening in other places. And one of the other switches is cancer is the leading cause of death in San Diego, where in the rest of the country it's heart disease. So we are essentially saving more people with heart disease. We're still working on cancer, but Alzheimer's is number 3 and will be moving up. Mary mentioned mentioned that a lot of Alzheimer's deaths are not reported as such, and that has to do with awareness and coding. Many of our primary care physicians don't have a lot of training in how to identify Alzheimer's disease, how to react when a patient comes in with concerns about their memory. So we have a lot of work to do, and that's one of the things the Alzheimer's Project is doing, is working with clinical teams to develop protocols and to develop ways of identifying early on when some of the drugs that are out there can actually have an impact on quality of life. Okay, so the scariest part of this one is that about a third to almost a half of people 85 and over have Alzheimer's, and that is our fastest growing demographic group in San Diego County. We looked at Alzheimer's disease, and then we also started looking, when we were gathering our data, at other dementias. And rather than just report Alzheimer's numbers, we decided to include other dementias because clinically it made sense. The kind of care, the kind of resources that are needed are similar with Lewy body dementia and with cognitive impairment, that all the numbers that we produce at the county are actually called ADOD, which is Alzheimer's disease and other dementias. And if you are concerned primarily about whether you're going to develop Alzheimer's or not, this doesn't tell you whether you're going to develop it. It just says that there are more people in East County that have Alzheimer's disease than anywhere else. And this is the projection going out to 2030. For the north, you'd be looking at the green bar and the purple bar and the blue bar. Okay? In sum, you've got about half the people with Alzheimer's, and those bars are actually growing at a faster rate. So we see a lot of, as I said, I spent the evening in the emergency department, and what we're seeing a lot of is people who were discharged with not just taken to the emergency department because of a diagnosis of ADOD, but for some other reason, but have a secondary diagnosis. And why this is important is it changes care. If you were to go in with septicemia or some kind of infection, which is a very common primary reason you go to the emergency department if you have Alzheimer's. If you have your functioning intact and you're able to communicate, it's a quick ED visit, it's getting antibiotics or something like that. If you can't communicate what's wrong, what hurts, it's a battery of tests. It also requires nursing or some caregiver to be with you the entire time, and ED waits can be exhaustive. The emergency department is also a hyperstimulating environment, which has a negative impact on someone with ADOD. And what that means is they tend to get very anxious and nervous, and they're more likely to act out, and this is not in a deliberative or thoughtful way, this is a reaction to the stimulation in the environment. And then when we look at emergency department or hospital discharge, again, look at the 2030 projections and look at the green bar. Then look at the purple and the blue bars. Okay, so as hospital systems, as healthcare systems, we need to pay a lot of attention to this because I'm expecting more growth in those areas than I am in other parts of the county. The other thing I wanted to mention is the county has services that we do provide, and one of those is public guardian. And that's where the county has to step in, because there are no family members or there are no relatives who can care for an individual who cannot care for themselves. Right now, 39 out of 100 public guardian clients are in fact have Alzheimer's or other dementia. When we looked at our behavioral health services, 262 mentions of Alzheimer's disease or other dementias were listed in clients 55 and over utilizing county services. Unpaid caregivers, this is the real burden. It takes over about 2.2, 2.3 caregivers per person with this disease. This is 24/7 watching. A lot of these people wander at night. A lot of people with this diagnosis cause self-harm or can harm others without intent. So you have to have someone watching, or you have to have someone available. This can be exhausting unless you have shifts. Okay, so not only do we look at the people who have the diagnosis, but we have to look at those family members, the caregivers, and the professional caregiving community that has to take care of or be there to support and care for the individuals. Caregivers experience emotional stress, depression. Oftentimes as a family member, what this is not just that you're having the physical exhaustion of caring for somebody without a break, but it's the emotional trauma of caring for someone who once was very important, you know, who knew who you were, who did activities with you and things like that, and then watching them either withdraw, get hostile, not know who you are, think that you're trying to hurt them. And that can have a devastating toll even if you understand the disease. But if you're not really familiar with the disease, you just know that this is happening to your person, your loved one, then it becomes even more of a burden. And we actually see a huge increase in medical costs for caregivers over the general population. See that big, dark, brown swath across the North County? These are people who currently report some level of cognitive dysfunction, okay? Mild cognitive dysfunction is usually the first signs, clinical signs of Alzheimer's or other dementias. If you want to get copies, we've done 2 reports. One is the economic burden of Alzheimer's disease. The other is prevalence of Alzheimer's in San Diego County. Both are available, as well as a bunch of other information and maps and things from our website. Just push the Alzheimer's button when you get there.
You know, I think I want to dig into Alzheimer's a little more. All 3 of you are on the county's Alzheimer's project. Cheer me up. What can we do about this? What can we do about it now? What can we do about it in 5 years? What can we do about it in 10 years? You know, I was talking to Mary recently, and she mentioned this amazing program to me called the Purple Angel Project. I can't remember the exact community that this is in. I think it's in Michigan or something, but it touches on something that I didn't realize, which is just how isolating Alzheimer's and dementia is for the caregivers. You know, I was talking to a local gentleman recently who said, you know, I can't go out to dinner, Paul. I can't go out to dinner because I don't know if my mom is going to start screaming when we get out of the car. My mom needs me to go to the bathroom with her, and that's really hard to do at a restaurant that really has a segregated male-female bathroom set up. So what the Purple Angel program does is it puts a little purple angel in the window of the restaurant or facility that says, hey, we are aware of, you know, what is needed to work with dementia and Alzheimer's folks. So they have a bathroom that's available for help if you need it. They have a better understanding if there's going to be an outburst or something. And so I think that kind of speaks to, you know, it's not just about cures. It's not just about, you know, fixing things in people's heads. It's also about kind of surrounding the people who are going through this in a better way than we are right now. It seems like we as a community might need to find a better way to help the people who are in their homes trying to deal with this. So I guess that's kind of how I would frame this. So what are we going to do about this, guys? Come on, cheer us up. How are we going to fix this?
Well, Paul, I'll start out. The Purple Angel program, it's a program about raising awareness within communities about people living with Alzheimer's disease and their caregivers, and providing support and acceptance. Because oftentimes, people with this disease will exhibit behaviors that they would never have exhibited prior to having the disease. And Leslie shared a little bit about what's going on with her mother-in-law. You know, you will see folks get agitated, they may get angry, they may yell. And so the Purple Angel program is really raising that level of education in the community so people can be accepted. And the county's Alzheimer's project is really just a wonderful start about raising awareness in the community. There are 4 roundtables as a part of that project, so really kind of 4 work streams. One is about public education and awareness, so the community understands what are the signs of Alzheimer's disease. So when we see our neighbors leaving their front door open overnight, that we go over and ask them if they need some help or assistance, because they may just not remember that their front door's been left open. You know, it's about, you know, looking for people who may need some help, they may need a diagnosis, they may need some steps to keep them safe. So the awareness is a key part of the Alzheimer's project. There's a clinical roundtable that Dr. Lobatz is chairing, and he has done a phenomenal job leading physicians from all of the healthcare systems in San Diego County to develop a standard for diagnosis and standards of care for people with the disease. And that is no easy undertaking. You know, he is in a room with lots of physicians, lots of neurologists, and I think you've probably learned a lot about doctors through that process. Then there is another work stream on care and support, and that involves many partners from county departments, the sheriff's department, and then agencies out in the community about developing capacity. How are we as a county going to support the more than 60,000 people today and the more than 100,000 people, you know, by 2030? We've got to figure out as a community how we're going to help those families and keep people safe. And ultimately, that will help in the healthcare arena. And then lastly, we started out with a research roundtable with representatives from all the different research institutes that we have here in San Diego. And first started off just people having conversations about what they were working on, and then really developed a laser focus on drug discovery. Because at the end of the day, we need a drug. We need some kind of a treatment that's going to slow this disease. With the help of the county, Darlene Shiley, you know, who is a well-known philanthropist and has done more in the fight against Alzheimer's disease than I think anyone out there in the county, we were able to raise $500,000, and recently, going through a pretty rigorous process, selected 8 projects that we're going to run through the drug discovery process at Sanford Burnham or the Scripps Research Institute. And drug discovery is something that San Diego has very unique expertise and equipment with the people and resources at Sanford Burnham and Scripps. So we're taking advantage of that and taking a lot of the great work done at other institutes in San Diego and at UCSD and seeing, is there some potential for what they're working on to be turned into a drug? So that all started through the county's Alzheimer's project. So a lot of work has been put into it, a lot more work is going to be put into it, and we're starting to make some progress.
I would say to Dr. Lobatz, we have spoken before about this project, and you've talked to me a lot about the work that you guys are doing to come up with a common diagnostic tool. I didn't realize there wasn't one, but there isn't, so imagine that. And Mary brought something up to me recently as well. There was recently a study that indicated that a large percentage of doctors do not inform their patients that they have Alzheimer's. So I thought that would be a good way to frame.
Right. Thank you. So the clinical roundtable is made up of physicians from all over the county, South Bay, North County, East County. And it includes neurologists, geriatricians, geriatric psychiatrists, and various stakeholders from the caregiving communities, such as the Alzheimer Association, as well as the Glenner Center, Southern Caregivers, and so forth. So it's a pretty diverse group. And one of the first things we realized was that we needed to come up with tools for primary care physicians to be able to better screen and ultimately diagnose Alzheimer's disease. It would be wonderful if everybody could go to a neurologist to get their diagnosis, but there are simply too many patients with Alzheimer's disease in San Diego County, excuse me, that if we sent all of them to a neurologist, the neurologist would have no time to see anybody else. It would totally swamp the system. So it's extraordinarily important for primary care to take on some of the burden and work with this patient population. And a primary care physician today, it's tough. They have to worry about your blood pressure, your diabetes, your cholesterol. They have to do various health screenings, mammograms, pelvic exams, various things that fill their day so that when a patient comes in with a focused problem like, hey doc, I'm here for my regular checkup, but you know, my wife says I'm becoming forgetful. How does a primary care physician turn themselves from having to manage a myriad of other things that they have to worry about to really focusing on what's important for that patient at that moment? So what we've developed is a simple, algorithmically driven screening process for a primary care physician to be able to make an initial sort of impression within 5 or 6 minutes of seeing that patient. Something very simple that's easy to apply. And then if a person fails that initial screen, it gets a little bit more complicated. And one of the things that Mary and Paul just touched on is when you do arrive at a diagnosis, how much time do you need to spend with the patient and the family explaining what's going on and what the clinical course is going to be and what medications are out there and what clinical trials they might be interested in to try to help improve the disorder ultimately and treat it. That's an hour's discussion minimum, hour and a half in some cases. So finding the time to do this, doing it correctly, coming up with the right diagnosis, informing your patient is what the clinical roundtable is really all about. And I'm very pleased to say it's been a year of working on this. It's herding cats, definitely. When you get 5 physicians in a room, you get about 7 opinions about what to do. And, but eventually a consensus was made, and this is now being rolled out in a limited fashion to several healthcare systems in the county on a pilot basis to see how it works, with feedback coming back, and then it's really a living process that will change with time, and especially as new diagnostic and other criteria change. So it's been wonderful to participate in this, and I think it's going to make a big difference in our ability to make a correct diagnosis, timely diagnosis, and get patients into the proper care.
Leslie, I've seen some of the work you guys have done at the county mapping where the concentrations, the highest concentrations are of folks diagnosed with Alzheimer's and dementia, and I wonder if you might talk a little bit about kind of how we marshal resources around the caregiving side while these guys are looking for cool tools and diagnostic tools and such. How do we, you know, what do you see in the demographics in terms of the resources we can bring to this at a community level?
That's the easy question, right? We don't have enough day facilities or residential facilities, particularly in parts of the county where we have higher need. Oftentimes people will wind up having to travel quite a bit of length to actually get some either daycare or residential facilities for their loved ones. Where I see a lot of hope is actually just this summer, San Diego State University School of Nursing and School of Gerontology got one of the largest grants from the federal government in the country to train nurses and other paraprofessionals in care and management of patients with dementia. We'll start seeing the benefit of that in future years, hopefully ahead of the curve. But really in terms of trying to identify what areas resources are needed, clearly East County has a greater need, but places like Anza Borrego, which has a very small population but has a high percentage of people who are in the target age group, and when you think about it, your odds are pretty much 50-50 once you hit 85. So we need to start looking at where our seniors living, and we've done a lot of mapping in that. We need to also look at where our current facilities are and what their capacity is. A lot of these places are full already. And so what happens in 5 years? And what happens in 15 years?
Very good. I think we have, I don't know, about 10 or so minutes left on this panel, 15. I thought we could open it up for questions.
Any of the three of you contribute some information as to other predictors of Alzheimer's in the aging population other than just age, environmental, other health predictors?
One of my favorite things to tell people about that is that educational level is linked to the development of Alzheimer's disease. We don't exactly understand that. So by the virtue of the fact that you're sitting here today being educated about this, your risk has reduced very slightly. So there are a number of risk factors. Obviously, number one is aging. Other disease states are thought to be part of it as well. There's a lot of concern about glucose or sugar metabolism and diabetes and Alzheimer's disease. There are other forms of dementia, though, including other than Alzheimer's disease, such as multiple or vascular dementia, which is from strokes. So that's related to cardiovascular health, cholesterol, diet, obesity. Those kinds of things are also playing into it. Genetics appears to have a loose connection, and there's a very young onset in the 30s Alzheimer's type of disorder, which is strongly genetic, but that's very rare. And but as more genes are discovered, this may change over time. But the main is age. So the longer we live, the more likely it is we're going to develop this problem. And by staying healthy and fit, active physically and mentally, your risk goes down.
Jim D'Agostino, board member, also a practicing physical therapist. So these are my peeps you're talking about. Okay, we're all going to get a little bit less competent, and it is the belief of my people that our children are probably not going to have the assets to take care of us. We from the 60s grew up a little bit differently. We sucked it up, but we're not sure. So what we believe is going to happen is people are going to enter our homes and take care of us. But there's a security issue. Does the county have any thoughts for us about how these people come into our homes and how will we be protected?
We have some programs, Public Guardian, I've mentioned, Public Conservators. We have Adult Protective Services, a number of programs out of the District Attorney's Office to protect family members or protect individuals from either family members or others who might either basically abscond with assets and things like that. That said, one of the best things that you can do is look for qualified, reputable help coming in. We are, one of the things that this work with the School of Nursing and School of Gerontology will produce is a series of trained personnel who can deal with and understand the disease. Part of the problem is caregivers who don't understand the disease often react emotionally, and they feel picked on, they feel accused. My mother-in-law regularly accuses everyone under the sun of stealing her underwear. Trust me, nobody wants her underwear. But the underwear gnomes are out there, and they take her underwear, and we find it every time in her typewriter case because she's packing to make her escape. It's making sure that as you bring people into your home, you're bringing people who are reputable. You can look into agencies or bonded agencies who will ensure that. You also have to make sure that as you're bringing people into your home, you bring in people who understand what is going on with you, what the disease is, so that they can react appropriately, not react.
We meet with families, dozens of families every week. And usually one of the first questions, it's, how many oldest adult daughters in here? Oldest adult daughters, okay. A lot of times it's the oldest adult daughter who will be in our office and say, my mom has Alzheimer's disease. We're to the point we can't leave her alone. What's Medicare going to cover? Because I can't leave her alone anymore. I work, and we're worried she's going to leave the stove on, or she may wander, because statistically 6 out of 10 people with Alzheimer's disease wander. That's a big risk factor. And the answer is Medicare is not going to cover much. So the next question is, well, how much does care cost to have someone come into my home? And it typically runs $20 to $25 an hour with a 4-hour minimum. So to have somebody come in for 8 hours, there's $200 a day, 20 work days in a month, because the oldest adult daughter has to go to work. All of a sudden, you're at $4,000 a month. That's out of reach for most of the people we talk with, and I think it's out of reach for most of the people in this county. So then when you look at adult day programs, depending on, if you can get some government assistance, you might get a reduction, but that's $80 to $100 a day. So when you talk about who might come into your home to care for you, at this point in time, since there's not much that's reimbursable and it's out of pocket, it's most likely going to be family members or some type of a patchwork arrangement. It could be, friends, family members, and that's difficult. That's difficult to do for 5+ years. And as a nation, we've got to figure out how are we going to support these caregivers and their families as they're caring for this person with the disease, because it's a 24-hour-a-day job. And there aren't a lot of resources out right now that are reimbursable. And that's one of the things we're focused on through the county's Alzheimer's project is how do we get more programs available that aren't necessarily income-based? Because people who are middle class, there aren't a lot of resources available to them. So that's one of the things we're really looking at countywide to see, we've got to build more programs, we've got to have more options for families. And then of course, security is always an issue. For most of our families, we don't even get to that because we've just got to figure out how to get them a break and get some care in the home to relieve that caregiver.
For the initial screening that you have developed with the roundtable, is there anything that can be done to put that online for those of us who suspect an elderly relative may be going down this path, and that would help us to understand a little bit better how to manage that?
So yes, these algorithms will be made available on the county website to begin with. I think the Aging and Independent Services website, they're developing a whole web presence for all of the roundtables that are occurring right now, including access to clinical trials. And the treatment algorithms, we didn't really talk about that very much, but there are treatment algorithms being developed for things like agitation, combativeness, wandering, and so forth. And working with our colleagues, particularly at UCSD in the geropsychiatric community, recognizing the driver of a behavior like agitation or combativeness is critically important, and addressing that in a behavioral way rather than with medication may be much more effective. The knee-jerk right now is for most physicians to prescribe a medication to control the behavior, which may or may not be the right medication. Example would be, it's very common for Alzheimer patients to become depressed. And that depression may show up with various kinds of behaviors. If you were to treat the underlying depression rather than try to treat the behavior, you would get better success. So there are algorithms being developed for that as well. And their education of the caregiver community is critically important for this, because the physician will only be able to make the decision based on the information that they receive about what's happening at home. So the caregivers are there, the eyes and the ears, and educating them about what to look for, how to record it, so that when you do come into the doctor, that the doctor has an idea of what's actually driving the behavior is critically important. So all of this is going to be on the web, along with a lot of other material, and thank you to the County of San Diego for actually providing all of the resources for this, as well as funding for the various activities that you just heard of. It's unprecedented in the United States, for as far as I know, for a county to do this. And kudos to our Board of Supervisors and Diane Jacob for that.